يعطيكم العافية. أنا دكتور خالد الحصري، استشاري دماغ وأعصاب وأمراض صرع epileptologist or neurologist بهوبكنز. So بدنا نحكي شوي عن ال epilepsy diagnosis و anti-seizure medications و try to go more أكتر بال anti-seizure medications و side effects و interactions و how to use them. و please feel free to ask me questions. وإذا بدكم أدوية تانية، أنا حطيت ال most common وال available، بس إذا بدكم أدوية تانية نقدر نحكي عنها يعني بدون السلايدز. As you know, approximately 5 to 10% of the population will have at least one seizure at some point in their lifetime. So it's not rare. I mean, it's actually, you know, fairly common, right? Half of these, they occur usually during childhood and adolescence. Usually the highest risk is before 1 year. However, remember that the incidence of unprovoked seizure is also increases, you know, in adults and in the elderly older than 65 years old. So we have this bimodal distribution of seizures, right? So this is a nice curve. Actually, it was published recently 2 years ago, and it showed that, you know, even for unprovoked to provoked seizures, which we're going to talk about them, almost all of them, they have this bimodal distribution, right? Even for the seizure mimics, which is usually, you know, it could be a syncope, it could be cardiovascular. It makes sense, Bardo. So everything, you know, increases as we go older, right? So over 65. So as you can see, unprovoked seizures, provoked seizures, epilepsy, and even the seizure mimics, which are, you know, on the differential diagnosis, also increases بعد 65 years old. Same thing happens, you know, younger than 1 year old, and, you know, in childhood as well. We always have these three main questions, always tell the residents, you know, whether this is a seizure or not a seizure. And then the second question is, if it was a seizure, is it a provoked or is it not a provoked seizure? And then if it was unprovoked seizure, what type of seizure was it? What's the risk of recurrence? Do we need to start anti-seizure medication and counseling as well? Now, the differential diagnosis of seizures, as you all know, it could be either two big groups. I usually divide them into either epileptic or non-epileptic. So epileptic seizure, it could be a provoked seizure, it could be an acute symptomatic seizure, or it could be just an unprovoked seizure. And it could be either a focal onset or a generalized onset. Now, the non-epileptic, you know, you could be goes more with syncope. So very common. That's probably the common, which is, you know, vasovagal syncope. Migraine, it could, you know, look like a seizure, right? TIA, transient ischemic attack, psychogenic non-epileptic seizures. It could be some sort of movement disorder, maybe a dyskinesia, maybe like a medication reaction with extrapyramidal symptom, transient global amnesia, sleep disorders, you know, parasomias and sleepwalking, vestibulopathy, you know, if you have a very severe dizziness, you could actually pass out and fall on the ground, right? And the other thing is just encephalopathy and altered mental status can, you know, look like post-ictal or could be a seizure itself. Now, it's all about the history and the episode itself. I mean, the history is the money here, you know, in diagnosing these patients. And sometimes it's not, you know, 100% available, right? But try to tease it as much as you can. So we have the scenario and the situation. So how the body position, was it an upright? Was it sitting? Was it a supine? You know, you don't have syncope if you are supine, you know, unless you have a cardiac, you know, arrhythmia, right? So it's unusual, right? Awake versus asleep, you know, anything that happens from sleep is a little bit concerning, you know, for some sort of a seizure, right? Because if you remember, movement disorders, they don't, like a tremor or a dyskinesias, they go out with sleep, they resolve. However, a seizure, it can persist, and it's usually, you know, it's more common a little bit in sleep as well. And remember the patient experience and recollection of the event. So the event tempo, so characteristic of any abnormal movements, right? And the cardinal sign of seizure is this stereotypic nature. It usually happens again and again. It's the same thing, right? For each patient. And it gives you this sudden onset of symptoms. And you have a rapid crescendo to the maximum severity. Like in neurology, you know, there's usually three things that give you this sudden onset of symptoms, right? So you have, it's either a seizure, it's either a vascular, or it's either, you know, a little bit migraine as well. Migraine, it tends to be over minutes rather than seconds, but usually the seconds, it's usually a vascular or a seizure. This is very fast, whatever symptom you have. So the tempo of the onset of symptoms, that gives you the clue, the diagnosis. And then, the witness description, right? Whether the patient has at first stiffening and then shaking, how long was the shaking, or whether the patient fell on the ground first, lost tone, and then started having shaking. If in that case, it's usually a convulsive syncope, because you have the loss of tone at first, and then we got a little bit of a couple of beats of convulsive syncope or convulsive jerking. Preceding symptoms and aura, did you have any, there are things that goes with syncope, things that goes with seizures. That goes with syncope is more with this lightheadedness, dimming of the vision, palpitation, flushing, right? Fullness in the ear. All of this, it goes with a syncope. The things that goes with the seizure is usually more specific. So, you get this nausea or rising sensation, in the stomach, right? And then duration of the event, most of seizures, about 95%, they last within 2 to 3 minutes, and then they stop. Longer is usually atypical. If the episode lasted for longer than for 5 minutes and 10 minutes, this is very unusual for seizures. Post-event confusion, aphasia, weakness, and what's the duration of them? And then if you have tongue biting and urinary incontinence, and then any injuries. I had a patient, 2 weeks ago who had first time seizure, and then she fractured her arm here. So, it's not uncommon, but it happens. And then ask about any prior episodes, whether you have any prior episode of jerking or myoclonus. That gives you more, are we dealing with a generalized epilepsy syndrome, more with a JME or childhood absence epilepsy. The other thing is prior episode of staring spells. These are the absences, prolonged daydreaming, activity interruption, memory lapses, and lip smacking. It goes more with a focal, unaware seizure or complex partial seizure. And the same thing, prior paroxysmal episodes of abnormal feelings and sensation, like an intense nausea, anxiety, deja vu, sensory vision, and so on. Some triggers of seizures, the big 2 triggers of seizures, they are usually sleep deprivation and excess alcohol intake, like binge drinking. Medication as well, it can, the common one is bupropion, Wellbutrin, that's big one, tramadol, clozapine, some cephalosporins, and the fluoroquinolones. The risk factors of epilepsy, you all know them, whether you have, it's usually, you have an injury, that happens either during childhood or something, or neonatal period or perinatal period, right? So febrile seizures, if you have prolonged and complex febrile seizures, that will be a risk factor for epilepsy. Family history of epilepsy, family history of, other mental illnesses and other neurological disorders, that gives you more, is there a problem? Is there a disturbance, maybe a channelopathy that gives you, the seizures here, and gives you the psychiatric and the mental illness in other patients. Now, prior history of traumatic brain injury, of course, and then how long is it? How severe? Did you, is it loss of consciousness or not? Do you have amnesia or not? Prior history of stroke as well and encephalitis. These will give you, very, very high risk of having recurrence of seizures. The symptoms, of course, remember. So again, this is the big thing to differentiate whether it's a syncope of seizure. And a lot of patients, this will be misdiagnosed, a lot of time. So you want to make sure, not to diagnose patients with seizures when they're actually having syncope. The symptoms favoring seizures is the specific aura, urinary incontinence, lateral tongue biting, slow return of consciousness with subsequent confusion, which is the post-ictal state, headache, very bad headache, drowsiness, and Todd paralysis, which is unilateral weakness in one side or the other. Okay, any questions up until now? Okay, let's talk about a little bit the definition of, so a seizure is a transient occurrence of signs and symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. Now, acute symptomatic seizure is a seizure occurring in a close temporal association with a transient central nervous system insult. So for example, the patient is having now an encephalitis and they have a seizure. So we call this an acute symptomatic seizure. Now, a provoked seizure is usually a systemic illness. So you have a hyponatremia and the patient had a seizure, so that we call it a provoked seizure, right? Epilepsy is a disease of the brain, which is defined by any of the following. So you have two unprovoked or reflex seizures occurring more than 24 hours apart. If you have one unprovoked seizure with a probability of further seizure is quite high, at least 60%. And you have three is the diagnosis of an epilepsy syndrome, you know, based on the clinical and the EEG features. Any questions? So common causes of acute symptomatic and provoked seizures, you know, we have hypernatremia, hyponatremia, hypoglycemia, glucose abnormalities, you know, we have DKA or hyperosmolar non-ketotic coma, uremia, hepatic failure, very low levels of magnesium, calcium, phosphorus, and then drug of abuse, drug withdrawal, some medications, as we mentioned before, hyperthermia, and hyperthyroidism as well. Now, acute symptomatic seizures is usually, you know, CNS infections, CNS inflammation, eclampsia, hypertensive encephalopathy, hemorrhagic ischemic stroke, and vasculitis as well. Okay, so we saw this patient, we decided that the patient has unprovoked seizure. So, you know, we were sure that the patient had the seizure, number one. Number two, there's no provoking factors or acute symptomatic, you know, CNS illnesses. So we think that the patient has an unprovoked seizure. So what's the seizure recurrence now? Remember that the chance of a seizure recurrence is greatest within the first 2 years after a first seizure. In general, as a ballpark, the risk of second seizure after an unprovoked seizure is about 33%. Okay, now it's variable between about 20% up to 50% depending on specific features. Now, after a second seizure, and we'll show you the curve, the risk of a third unprovoked seizure is about 76%, right? A good rule of thumb in medicine, usually the percentages is a third. So if you're not sure about the percentage, just go with the third, and you will be, you know, probably right. Now, risk factors for seizure recurrence. So what are the factors that put the patient not at the 20%, but actually at the 50%, you know, or the 45%, where you have a higher risk of having another seizure, right? So if you have a prior brain insult, such as a prior stroke or a trauma, you know, with an encephalomalacia, this is a very high risk of seizure recurrence, right? If you did an EEG and you have a clear-cut epileptiform abnormalities, you know, we have spikes, you have sharp waves, so that also will put you at a high risk of recurrence. Significant brain imaging abnormalities, you did the head CT or you did a brain MRI that shows significant cortical encephalomalacia, so that will give you also very high level or very high risk of recurrence. Now, nocturnal seizure is also a little bit higher as well. You know, if a seizure happens from sleep, that means that it's more higher. And probably the reason it's higher is that because the misdiagnosis in the studies, it was, I would say it was less, because, you know, if you have an event that happened from sleep, it's a higher likely that it's actually an epileptic seizure rather than, you know, something else or a seizure mimic. Now, less likely where you have, it's still a higher risk, but not as strong as the first four, where you have the elderly and you have children, a positive family history, we have a febrile seizure and an abnormal neurological examination. Okay, so this is the risk. This is a very old study, but, you know, it's fairly a landmark study. So they followed patients with first seizures and they looked at what's their risk of recurrence. So this is a patient with first seizure, as you can see here, and the risk is approximately, you know, around the 30%, you know, so less than 40%, right? And look how the curve plateaus. In all of the studies, the risk is highest within the first 2 years. It's mostly within the first 1 year, as you can see, and then it kind of plateaus here. Now, what happens? if you have a third seizure, what's the risk of a third seizure after a second seizure? It's very high. So almost, you know what, almost 70%. So if you have 2 seizures, then you met the diagnosis of epilepsy. And that's why the diagnosis of epilepsy, it's 2 unprovoked seizures, right? Because then the risk of a third seizure is very high. Now, look at the risk of the 4th seizure after the 3rd seizure is almost identical to the 3rd seizure here. And it tells you that after you reach this threshold of 2 seizures, then, you know, your risk is, that's it. You just meet the diagnosis of epilepsy, and, you know, your risk is fairly comparable, no matter how many seizures you have. Okay, any questions? This is again, this is another study that looked at what's the percentage of patients that they have seizure recurrence, and again, with the time scale here on the x-axis. And as you can see, the same thing, it's kind of plateaus as well, where most of patients, they have the seizures recurrence within the first 2 years, and most of them actually within the first 1 year. Now, we said that nocturnal seizures occurring from sleep, they are slightly have a higher risk of having seizure recurrence compared to daytime seizure. And this is actually taken from 2 studies back in the 90s, where they looked at the time where the seizure occurred. So this is the first one. Here is from 9 a.m. to midnight, and then here is from midnight to 9 a.m. And this is the probability of remaining seizure-free. So this is a Kaplan-Meier curve. And as you can see here, the probability of remaining seizure-free is higher in patients with daytime seizures compared with patients with nocturnal seizures. And the same thing was replicated in a different study with fairly similar results, as you can see. So if you have a nocturnal seizures, you have a lower risk of remaining seizure-free, you know, which means that a higher risk of having seizure recurrence. This curve and this study, it looks at the difference between acute symptomatic seizures and the difference between first unprovoked seizures. So if you have an acute symptomatic seizure, your risk of having subsequent seizures it's actually low. You know, it's not high at all. So if you have an encephalitis and you have 1 seizure, then you don't need to put the patient on long-term seizure medication because the risk is not high. And however, if you have an encephalitis now, and a month later you have a seizure, then we will consider that a remote symptomatic seizure, and then it will be very high risk of having recurrences. So for example, if you have an acute stroke and a seizure, your risk of having a subsequent seizure is about 33%. However, if you have a remote history of stroke, your risk of having a subsequent seizure is about 71%. So very, very high. You know, same thing is replicated in CNS infections. Look, 16.6% with the acute onset, and then if you have a remote onset of CNS infection is about 63%. And same thing with traumatic brain injury as well. Any questions about this? Or before? Am I going too fast? Or okay. Now, if you remember in the diagnosis is that the 2 seizures, they should be more than 24 hours apart. So why is that? Yeah, I mean, and this is actually, it came from 1 study that looked at the difference of recurrence between multiple seizures in 24 hours or a single seizure. So what they did is that they had 72 patients with multiple seizures in 24 hours, comparing to about 400 patients with a single seizure. And the risk is almost identical, right? So if you have multiple seizures in 1 day, it does not mean that you're going to have a higher risk of seizure recurrence in the future, okay? Compared to a single seizure. Okay, now, so we diagnosed this patient. We said that the patient has epilepsy. So remember, about 50% of patients who present with the first seizure, they had a prior, you know, episodes of seizures before that they were undiagnosed, okay? So it's very common. Now, we diagnose the patient with epilepsy. Now the next step is to classify the patient. We need to classify what type of epilepsy they have. So we have two big groups. It's either a focal onset and it's either a generalized onset. And the reason for that is because the management is completely different between focal onset and generalized onset. We think of focal onset, which is the partial onset, the old name, is that the seizure starts from one area of the brain and then it can spread. Now, with the generalized onset, we think of it more as a thermostat problem. So we have just a higher risk or a lower threshold, of seizures in all over the brain. And just the seizures start almost simultaneously in all over the brain. And unknown onset if you don't know, right? So the focal onset, we can divide them into either a focal aware, which is simple partial seizure, or focal unaware or impaired awareness, which is the complex partial seizure, the old name. Now, and we have focal to bilateral tonic-clonic seizures. So if the seizure started as focal onset and then it went into a bilateral tonic-clonic seizures, we can divide them further. This is a little bit more, complicated definitions, which is, if you want to divide them into motor onset or non-motor onset. But I think the big thing is to divide them into either an aware and impaired awareness. And the way we test that, the aware and impaired awareness, you look for, just one second. Sorry. So the most important thing is the awareness, whether the patient is aware or we have impaired awareness. And the way to test that is to ask the patient whether you lose, time and memory as well. So, and the awareness, remember, it's not a black and white. It's not like flipping a switch, because it's more of a gradual and it's more of a spectrum. So patients, they could remember few things, but then they forget the rest. And they could be aware initially, and then they become unaware. So it's not, it's not an easy black and white, okay? Now with the generalized onset, we usually divide them into motor, or usually divide them into absences. Absences, which is, it's usually in kids where you have this, we call it absence epilepsy or absence seizures. And then the motor, which is either you have a tonic-clonic, a tonic or myoclonic seizures. Any questions? Oh, sorry. Any one second. Oh, what happened here? Okay, sorry about that. Any questions? Okay, let's talk a little bit about medications now, which I want to focus here. So we have a lot of anti-seizure medications. If you can see, this is a curve that's always shown, and you can see this exponential increase in the number of medications that we have. Started with bromide in the 1800s, and then the first one was phenytoin and phenobarbital in the 1900s. And then etoxamide and carbamazepine came, and the Depakote came in the 60s. And then we kind of have, no seizure medications for several years. And then back in the 80s and the 90s, we started having more and more medications here. Zonisamide, topiramate, Keppra, and then more recently, we have a lot of other medications since the 2000s as well. The most recent one is called Xcopri or cenobamate. It was approved in 2020. It's a very good medications, and we have good success and good response factors. So I just wanna, so I think, you know, of course, phenytoin and phenobarbital, they are available. Depakote is also available, right? And carbamazepine is available, right? Zonisamide, have you ever heard, guys, of zonisamide or no? Okay, how about lamotrigine is available, right?
Yes.
Yeah, and gabapentin, of course, is available. Topiramate is available. Topamax.
Yes. Yes.
Okay, good. And then oxcarbazepine or trileptal is also available.
No.
Yeah, it should be. And Keppra, of course, is available. Good. How about Vimpat or lacosamide? No. Okay, that's what okay, excellent. So we have a good, so we can talk about all of the medications that you want. I just want to emphasize that the choice of the anti-seizure medication, it should be depend on, you know, the type of the epilepsy, whether you have a focal or a generalized epilepsy. And the second thing is the side effects. Okay, you want to make sure that that drug works well for this particular patient. And remember, certain AEDs, they can make generalized epilepsy worse. So absence, they can make it worse, right? So carbamazepine and phenytoin can make absences and GTCs worse in generalized epilepsy. For example, lamotrigine can make myoclonic seizures rarely worse as well. Topiramate also is not effective for absence seizures. Same thing with zonisamide, has limited, right? But remember that, you know, the sex of the patient, the age, the patient comorbidities, other medications, drug-drug interactions, and the cost of the medication as well is very important to consider before you choose the medication. Now, out of all of these medications, how are we gonna pick? How are we gonna choose? So we have a lot of studies that looked at, not a lot of them, they looked at, you know, head-to-head between them. Most of them, they compared them to carbamazepine. And I just want to emphasize two big studies from Europe. This is called the SANAD-1 study in 2007. And then there was a follow-up study called the SANAD-2 study, which was published last year. Now, the SANAD-1 study, they had two arms. The first arm is for focal epilepsy, and the second arm for generalized epilepsy. Okay. Now, what they did is it was an unblinded, randomized controlled trial. It was in the UK, the United Kingdom. Okay, and they have approximately 1,700 patients, where they randomly assigned them to receive either lamotrigine, carbamazepine, topiramate, or gabapentin. Okay, and they followed these patients, and they looked at the primary outcome was the time to treatment failure and the time to 12 months remission. What they found is that lamotrigine was significantly better than all of the others, you know, for time to treatment failure, meaning that it has much less side effects and also more, somewhat more efficacy, right? In terms of carbamazepine, gabapentin, and topiramate. It has a non-significant advantage with oxcarbazepine. Okay, so this is, so out of the SANAD-1 trial, they found that lamotrigine is probably the best tolerated and most efficacious as well, you know, comparison. Along with carbamazepine. Look at the difference here between gabapentin and topiramate. They're not as good as these two, but the lamotrigine has a better side effect profile compared to carbamazepine. Now, the generalized arm, they looked at three medications. They looked at depakote, valproate, lamotrigine, and topiramate. So what they did is that they found that valproate and lamotrigine, they were much better than topiramate. Okay, and you show that actually depakote or VPA was significantly better than lamotrigine overall for patients with generalized epilepsy. So there's differences between generalized epilepsy and focal epilepsy. Now, what they did is more recently, they did the SANAD-2 study, which is, you know, a little bit of a follow-up. So they compared Keppra, zonisamide, and lamotrigine as a first-time treatment for patients with newly diagnosed focal epilepsy. And the doses, they were not very high. You know, 150 per day of lamotrigine, 1,000 milligram of Keppra, and 200 milligram of zonisamide. And what they found is that, you know, the Keppra was not better actually than lamotrigine. And in terms of side effects profile, lamotrigine was the better tolerated out of the three of them. So overall, lamotrigine tends to be slightly more, has a better side effect profile compared to Keppra and compared to zonisamide as well. And they looked at the time to first seizure, that it was almost identical in the three medications. So the lamotrigine, the Keppra, and the zonisamide, the time to first seizure was identical. And this was a concern, is that when you start lamotrigine, you have to start at very slow titration to prevent or to avoid the complication of Stevens-Johnson syndrome. But however, they show that actually it does not put patients at a higher risk if you go with the lamotrigine route. So it tends to be my drug of choice for patients with new diagnosis epilepsy, because it's well tolerated, efficacious, and does not have the side effects with the other medications. The only problem with lamotrigine is that it has to be slowly titrated. So I usually start at 25 milligram at bedtime for 2 weeks, and then I go up to 25 in the morning, 25 at night for another 2 weeks, and then I go to 50 and 50 for 2 weeks, and then I can go up to 75 and 75, and they usually stop at 100 twice a day or 150 twice a day. But it's a gradual titration every 2 weeks, remember. Once you hit the 75, you can start doing it faster every week. Okay, but the first 3 titrations has to be every 2 weeks to prevent the side effect of Stevens-Johnson syndrome, you know, and very bad rash. Okay, the side effect to look for in lamotrigine can give you, very rarely it can give you headache. Otherwise, it's a very well tolerated medication actually. You know, it doesn't give you sleepiness, it does not give you fatigue. It's a mood stabilizer, so it doesn't give you the angry and the irritability that we see with the Keppra. And it can cause a little bit of insomnia sometimes. So these are the 2 things that can cause with lamotrigine: headache, a little bit of insomnia. Otherwise, it's a very well tolerated medicine. I usually use it as my go-to in patients with, you know, new onset epilepsy. Now, the reason we do divide the patients or the medication into 2 big groups, which is the broad spectrum and the narrow spectrum. Lamotrigine is a narrow spectrum, but it does have a little bit of a broad spectrum as well. So it works on both types. Brivaracetam, which is a cousin of Keppra, is just a better Keppra. Clobazam is a benzodiazepine. It's very good for patients with Lennox-Gastaut syndrome and with patients with like intractable epilepsy and developmental delay. Keppra, felbamate, we don't use it as much anymore. Perampanel or Fycompa is a very good medication for tonic-clonic seizures. Rufinamide, it's very good for drop seizures, you know, in Lennox-Gastaut syndrome. Depakote, we're going to talk about it in detail. And zonisamide is actually a Japanese drug that came to the US about 10 years ago, but it has been used in Japan for, you know, decades. And it's, you know, it's very good for both focal and generalized as well. Remember, ethosuximide only treats absence seizures, does not treat tonic-clonic seizures. It works on the thalamus, on the T-type calcium channels. Any questions? Okay, let's talk a little bit about the anti-seizure medications. So Keppra or levetiracetam is about 95% bioavailable. It's a broad spectrum, so it works for both focal and generalized epilepsy. The way it works, it binds to this SV2A, which is synaptic vesicle protein 2A, and it inhibits that, and it inhibits the release of the neurotransmitters. It's not protein bound, so less than 10% of it is protein bound. The half-life is about 8 hours. However, it is given twice a day, so it's a twice a day medication. And Keppra is mostly eliminated from the kidneys. It has no adjustments is needed for the liver because it's not metabolized by the liver at all. about 2/3 of the dose is excreted unchanged in the urine, and the remainder is just metabolized through hydrolysis. Okay, the elimination of Keppra is significantly delayed in the presence of renal failure. So renal failure, it will mess up with the Keppra doses and with the levetiracetam. It's completely independent of the cytochrome P450, so no adjustment is needed for hepatic impairment. Okay. However, for renal failure, you have to decrease the dose. And for hemodialysis, you have to give a supplemental dose of about 250 to 500 milligram after each hemodialysis session. Now, the side effects, the big three side effects of Keppra are fatigue, that's number one, sleepiness, about 15%, and it gives you behavioral side effects, which is about 13 to 15%. And the behavioral, just irritability, mood swings, and these are the big three side effects. I always like to start very low dose and then gradually go up. And because, you know, if you start low dose and gradual, it will be better to tolerate it. And the patients, they will stick with the medication rather than switching it. So I start with 250 milligram at bedtime, so very low dose for about 1 week. And then I go up to 250 twice a day. And then I go up to 500 twice a day. And usually the 500 twice a day is the initial target dose. And then you can go up on it to a maximum about 3 grams to 4 grams. You know, more than 4 grams, I mean, you shouldn't go up more than that. In kids, we usually start with 20 mg per kg per day. The maximum dose in pediatrics is about 60 mg per kg per day. Remember, in the elderly, the clearance of the medication is less, is decreased. The half-life is longer. So that's why you need to lower doses. So for example, in the elderly, you know, more than 80, more than 75, you could only start them keep them at 250 twice a day, because that would be fairly enough for them. Now, this is, you know, you will see this on UpToDate, or, you know, if you Google it, it's fairly available, how you change the dose of the levetiracetam with renal failure. So if you have a mild renal failure, you got to decrease it to maybe 500 to 1,000 twice a day. If you have more severe, then you got to decrease more and more to about 250 to 500 twice a day. And again, as we mentioned, you need a supplemental dose of 250 to 500 following each hemodialysis session. Okay, any questions? Okay. Yeah, sorry. Any questions? Okay. Let's talk about phenytoin or the dilantin. So phenytoin or dilantin is the sodium channel blocker. It's a very focal onset. So it's a narrow spectrum medication. And it comes in an oral, of course, and an IV formulation. The oral, it comes in 3 formulations. It comes in the 100 milligram capsules, which is the extended release. And then it comes in the 30 milligram capsules, which is also the extended release. And then it comes in these 50 chewable tabs. Okay. Now remember that this is a little bit off. I think it's 2 details, but the 50 tabs and the suspensions are made up of 100% phenytoin. The others, the capsules, which is the extended release, it's made up of 92% phenytoin. So there is slight differences if you want to switch between them. I usually don't use the 50s. I usually do the 100s and the 30s, which is, so you get the 100 extended release of the phenytoin and the 30 milligram extended release. The absorption of phenytoin occurs in the duodenum. However, the absorption is not linear. It's a little bit erratic, and it depends really on the elimination. So if you have in phenytoin toxicity, the absorption can be very, very slow, and it can actually last for 60 hours because the receptors will be saturated. The peak dose after the PO administration is about 4 to 6 hours. 90% of the phenytoin is protein bound, is extensively protein bound, okay, and it's mostly to albumin. So remember, uremia, hepatic disease, AIDS, low albumin, and Depakote, they decreases the protein binding, and that will increase the free drug. And the free drug is all of that it matter in terms of efficacy, in terms of side effects as well. Okay, so all of these, and you have to adjust the dose. The volume of distribution is about 0.8, and it's almost exclusively metabolized by the liver. So no problems with kidney. However, with the liver, you gotta be very careful with using phenytoin. It's mainly metabolized by two enzymes, which is the CYP2C9 and CYP2C19. And the CYP2C19 is playing more important role when you have a higher doses, when you have, you know, a very high serum concentration, more than 18. Remember that the phenytoin has a zero order kinetics or nonlinear kinetics. So it means that it's nice and easy, and then it goes this exponential. So once you hit the therapeutic window, any small changes, it will cause a dramatic increase in the drug concentration. Again, the same thing. So patients with chronic renal failure has decreased binding capacity of phenytoin. So the percentages will change of the unbound. So you can use it. There's no problem. However, you have to monitor the levels. And if you can do the free phenytoin level, that would be even better. Usually, we don't advocate using it in severe hepatic disease. Okay, the oral load, if you want to load the patient with phenytoin, you can do oral loading, and you can give them 20 mg per kg, but usually divide them into 3 to 4 doses and give them 2 to 3 hours apart. Okay, so just divide it. So for example, if you have a 70 kilogram, so that would be 1400 or 1500. So you can give it maybe, 400 every 3 hours. So you can oral load, or you can give them IV, of course. Now, if you don't want to load them, the initial dose is usually 300 milligram per day. And you got to check a level. If the level was less than 10, the total, you can increase by 100 milligram. However, if the level is therapeutic, you got to make sure and increase by 30. Because if you are in this therapeutic range, remember, then the curve is going to go exponential. And any small increases, it will give you a big changes in the drug concentration. So if you have a therapeutic level, for example, 12 or 13, and you want to push it a little bit further, use the 30 milligrams. So increase by 30 or increase by 60, rather than increasing by 100, because then you will get the patient into toxicity. The side effects and toxicity of phenytoin, they are dizziness, imbalance, sedation, and nystagmus, of course, headache, and just encephalopathy as well. Long-term side effects of phenytoin, it affects the thyroid, bone density. It can cause low folate and macrocytosis. It can also affect the lipid profile. It's not very good medication to be on long-term as well. And it is teratogenic as well and gives you neural tube defects. Carbamazepine is a tricyclic anticonvulsant. It's structurally fairly similar to tricyclic antidepressants, right? It's a sodium channel blocker. The bioavailability is about 80 to 90%. Peak dose is about 3 to 4 hours after you take it. It's only available orally. Half-life is about 5 to 20 hours. It's a twice-a-day medication, so it's usually about 12 to 14 hours. The carbamazepine is metabolized in the liver by the CYP3A4 into 10-11 epoxide. This 10-11 epoxide is an active metabolite, and that will give you the side effects and will give you also the rash. Carbamazepine is an auto-inducer, meaning that it will induces the CYP3A40, and it will cause this auto-induction that takes about 2 to 6 weeks, and you might have a little bit of decrease in the blood level in 2 to 6 weeks because of the auto-induction. It's a very potent P450 inducer, so it has a lot of drug interactions, remember. Rash, so we do have this risk of Steven Johnson and toxic epidermolysis and necrosis. It's predominantly with this HLA-B1502, and it's very common in Asian patients. So it's not common in Arabs, it's not common in Caucasians, mainly in Asian patients. You have actually to test it. It's an FDA black box regulation, is that you cannot start carbamazepine on an Asian patient without testing for this HLA B1502. Side effects also, it can cause drug-induced lupus, can cause bone marrow suppression, leukemia, low platelets, can affect the lipids, thyroid, because it's an inducer, so that it will give you low vitamin D and osteoporosis as well. Can cause a little bit of weight gain and hyponatremia. That's the big, also, it's a big thing with carbamazepine. You start at low dose, 100 milligram twice a day, and then you gotta keep going up every week. Initial target dose about 400 to 800 milligram per day. We usually target a blood level of about 4 to 12, perhaps, in the 8 level is a good level. Oxcarbazepine or trileptal is fairly similar to carbamazepine. It is a prodrug, oxcarbazepine. It's a prodrug that is metabolized into these two enantiomers, which is R-licarbazine and S-licarbazine. Both of them, we call them MHD. The half-life of the MHD is about 10 hours. So it is also a twice-a-day medication. The oxcarbazepine itself, it's a prodrug. It's only for 2 hours. It does not have auto-induction, and it's a very mild P450 inducer. And it's a very weak inhibitor as well of CYP2C19. The side effect is much better tolerated than carbamazepine. So I don't use the carbamazepine anymore. So I usually use, if I want to use them, I use oxcarbazepine or trileptal. Much better side effects, less sedation, less interactions with medications. So very good medication. You gotta be careful with hyponatremia. Hyponatremia is about 2.5 to 5%. Okay, the risk is higher in the elderly, and the risk is higher in patients taking diuretics. The hyponatremia, it's usually, what happens is that it's more of a direct effect on the kidney tubules. So you just treat it with water restriction. So just a little bit of water restriction, and then the hyponatremia will resolve. You start with low dose, 150 twice a day, and then go up. The target dose about 450 twice a day. So maybe 900 is a good dose to 1200 milligrams per day. But it is much better tolerated than carbamazepine. Finally, I want to talk about Depakote. So Depakote is a broad spectrum medication, so works for both generalized and the focal onset. Works on GABA, NMDA, TTAP, calcium channel, a little bit of sodium channel. It's extensively protein bound, 90% protein bound. Half-life is about 13 to 16 hours. It can be less with other AEDs that they are inducers, right? It is metabolized by glucuronidation, beta oxidation, and cytochrome P450. And it's predominantly in Depakote is mainly liver, so hepatic induced. So you should not use it actually in mild to moderate hepatic impairment, and you should not use it in severe hepatic impairment as well. The Depakote, the effect, it does not have any effects on the kidney, and you can use it, but it's the same thing with the phenytoin, is that both of them, they are severely protein bound, and the presence of uremia changes the amount of protein bound, right? And that's why you can use them without any problems, but you gotta be careful with drug monitoring and with side effects. So with renal adjustments, just a quick summary, no dosage adjustment is needed with Depakote, phenytoin, carbamazepine, rufinamide, lamotrigine as well, phenobarbital, and clobazam. Now, with hepatic, you can use Keppra, you can use gabapentin, you can use zonisamide as well. So this is just an overview of medications and a little bit of management of epilepsy. What other questions do you guys have? أي أسئلة؟ في أي أدوية بدكم أحكي لكم عنهم ما حكينا عنهم؟
هي الفكرة يمكن إن when to start anti-seizure الريسك of recurrence صعب مرات نحسبه صح أو؟
Yeah, that's true. أكيد صعب. Yeah, فعشان هيك بدك تشوف imaging can help you, and also EEG as well can help you as well. Okay, and also you want to counsel the patients. The risk of recurrence as well, it really depends on the patient, right? So let me go back a little bit. So it depends honestly on the patient. You know, I mean, if for example, if the patient is out and about and you know, يعني إذا هو مثلا خايف من مثلا كمان seizure, I mean it depends, right? If a patient, for example, is sitting at home, you know, the risk is okay, so it's fine. So for example, in pediatrics and kids, we usually wait until the second seizure because you know they're not driving. The risk of death and SUDEP is extremely low. The risk of injuries is also extremely low. So it's okay to wait for a second seizure and then to treat. But it all depends honestly on the patient and how they, you know, and what is acceptable for them or not. Okay. Like, I mean, I had the patients who, you know, who had, you know, I was like, this is clear cut. You need to start the medication. And they were like, no, I just want to wait, which is fine if they understand the risks, you know. And then they have another seizure, you know, within 6 months, and then you can start the medication after. Okay.
شكرا.
Thank you.
أي أسئلة تانية؟
شكرا.
اوكي شكرا يعطيكم العافية. كيف الوضع عندكم؟ كله تمام؟
الحمد لله.
نشكر الله.
يعطيك العافية دكتور.
يلا يعطيكم العافية. نشوفكم إن شاء الله محاضرة ثانية.
شكرا جزيلا.
يلا يعطيكم العافية.